So you can see the screen, I guess.
Yes.
Okay, good. Yes, as Catherine said, I would like to now focus on transition, and that's also a topic that Gisela already mentioned. And as you will see, some of my slides or some of my conclusions will really go in the same direction also as long-term follow-up care in general, because this is quite related and connected, long-term follow-up care and transition. So I will first give kind of a definition, then some transition models that has also already been touched a little bit by Gisela. Then I will share with you some barriers and facilitators to a successful transition mentioned by survivors, but also by healthcare physicians. And then I will share with you some transition tools, which I personally think are really also helpful to use in clinical practice and daily use. So really broadly or generally speaking, transition, what does it mean? It kind of means that it's a process of moving from one setting to another. And as you can imagine, in a person's life, there are kind of some transitions and some changes, and also kind of related also to different developmental phases. For example, also just going from kindergarten to school, that's already kind of a transition and of a change of setting. And it's also kind of linked to leaving the comfort zone and kind of encountering the unknown. And I think that's also something important for childhood cancer survivors. Now, looking more for survivors, as already mentioned also by Gisela, there are kind of also two forms or two time points where a transition takes place. It's one where the patients go from the active treatment to follow-up care, but then also kind of from pediatric to the adult setting. And that's this type of transition I would like to focus on now in the next approximately 20 minutes. And here on purpose, I wrote it's kind of a purposeful movement. And these two words I think are really important, because transition really should be something purposeful, meaning that it's kind of, or it needs a preparation, and it needs a preparation of the survivors, but equally important, it also needs of preparation of the family, of the parents, but also the physicians, the adult physicians they transition to. And there also have to be found kind of an adequate time point. So it's not kind of possible to say at age 18, now you're adult and now you transition. So that's really important to find this point. And then also the term movement, because it's kind of, as I said before, kind of an abrupt thing that happens from one day to another, but it's rather really a process. And that also takes place in a individualized pace. And also, as mentioned shortly also by Gisela already, she mentioned the different long-term follow-up care models, but in a similar way, it's also it also influences the transition or the different transition models that can take place. And also, as mentioned already, what's really important, there's not one model and one transition model where you can say that's the perfect one and that should be used everywhere. So it really depends on what is possible in the individual countries, in the individual clinics settings, and what are also the desires from the survivors. And I think that's quite nicely summarized in a publication from Dixon et al. From 2018. And they kind of describe 5 different types of transition models, or also models of care. And I just quickly want to explain them to you. So the first one is the cancer center model. And that's really where the care is provided within a cancer center. And that can either be done by the primary oncologist, so meaning by the pediatric oncologist who kind of continues the care with its advantages and disadvantages as highlighted before. Or it can also be performed within this cancer center, but by a dedicated survivorship team. Another form is the shared care model. And there the care is initially provided by the cancer center, and then later it's transferred to, for example, a family physician or by someone in the community. But there is still an ongoing communication and also a support from the cancer center. This third type is kind of disease specific. And with this, Dixon et al., they meant that it's really still located in a cancer-based setting or in a survivorship clinic, but the care is rather focused on specific needs that can, for example, be specific needs of survivors of a brain tumor, where they may have more neurological or endocrine problems than other survivors. Then there is a risk stratified approach, and that means that it kind of stratifies the survivors in either they have a higher risk to develop late effects or a lower risk. And those with a higher risk are, for example, followed up still in a cancer center or in a survivorship care clinic. And those with a lower risk, they are then transferred to a family physician. And lastly, there is the consult-based model, where it is kind of a complete kind of transition and going away from the cancer center and also from the shared care model away to a purely follow-up care by the family physician. And in case that he would detect some problems based on the survivorship care plan he received also, then he would kind of contact the specialist he normally works with. So for example, when a survivor has later on dyspnea, for example, and he thinks there might be something with the heart, then he contacts the cardiologist he normally works with. In contrast to the shared care model, it would rather be then maybe the family physician would then contact the cardiologist from the cancer center. So that's a little bit the difference between these two models. But really importantly, as I said before, there's not one solution that fits all. It's really based on what's possible and what's available in each setting. And on the other hand, as also already highlighted by Gisela, there are really many players involved in such a also transition process, and that's also really important, that it's really also multidisciplinary. And these are just some, I think, key players in transition. So for sure, survivor, parents and family, but then also the pediatric oncology team, the adult providers, which can then either be hematologists, oncologists, or family physicians, and then the different medical specialists, for example, cardiologists or orthopedists, endocrinologists, and then also other specialists like social workers or psychologists. And I think what's really key also in this transition is that really all of these different players are really well informed, that they kind of have a common language, that they talk about the same, that they have the same level of knowledge. Also, as highlighted previously several times, that the communication is really key, and I will show this later on again. And also, as I said before already, that this really kind of individualized, and also the information each of these different players needs should also be individualized. And having in mind that there are so many different disciplines involved, it's also kind of not so astonishing that there are also barriers and facilitators for a transition. And that's what we once looked at in 2020 in a systematic review to really see what are barriers and facilitators for a successful transition. And we kind of found out that there are 8 main kind of areas where these barriers and facilitators can be put into. And the first one is, as you can imagine, the survivors' self-management skills, for example, knowledge and educational level, and also empowerment, that they can either be a facilitator or a barrier. The same is true for social environment, but also the survivors' personal feelings and emotions. And also, as you can imagine, differences in the pediatric setting or also in the adult setting can either have a positive or a negative impact on transition. As already mentioned also by Gisela, financial issues and insurance issues are important. Again, communication, and then also different structural circumstances. Now in the next slides, and I will absolutely not go into detail, but just show with you what are different barriers and later also facilitators mentioned, especially also by survivors and by parents and by healthcare providers in each of these 8 categories. So when we look at the self-management skills, as you may also understand, knowledge deficits in the survivors are a large barrier. So for example, when they're not aware what their disease was, what is the risk for long-term complications, and also why should they take, or why is long-term follow-up care important for them? If they don't know it, it's kind of a barrier. Also, the navigation in the adult system is really different from the pediatrics, and that can be a barrier. And on the other hand, and that was quite interesting also for me, when survivors, they reported when they only hear about, for example, that they heard that they had a cancer with a good prognosis for survival, with a minimal rate of relapse or minimal risk of late effects, that's rather something that they will not continue follow-up care after the transition in the adult setting. Looking at the social environmental factors, there are also parental factors that can kind of hinder the transition. For example, when parents are anxious, or they have kind of fear of losing also the control, because during the treatment, for sure, they had a lot of control and they were really engaged, and now also letting the child go, that might also be difficult and can be a barrier. Looking at survivors' feelings, so some said for them is cancer something of the past, and that's also then conceived as a barrier. And quite often transition also is together with other challenging changes in life. So with change in school situation or starting to work, and then maybe the long-term follow-up visits are not so important anymore. But lastly, I think that's also important, also having fear of potentially having a relapse or a new cancer or late effects, that can for sure also hinder the survivors to go to the visits after the transition. In the pediatric setting, it's rather, that's also what the physicians say, sometimes it's for them also not so easy to let the survivors go because they know them for so long. There's also kind of an attachment. So that's also can be a barrier. And what for the adult physicians, but also the survivors said, so when they're not really comfortable and they're not familiar with the survivors, then it's also perceived as a barrier. And as I said already, the environment in the adult setting is really different from the pediatric and may be perceived sometimes as a little bit cold compared to pediatrics. Also having questions and not being sure about health insurance and how it will continue with the medical costs, that can be a barrier. And also mentioned by survivors, when they think that there's not a good communication also between the physicians, the pediatric and the adult setting, that's a barrier. And on the other hand, you can also imagine that when we look at it from the other side, the things that I mentioned as barriers, when we turn them around, they can also be facilitators, meaning well-informed and well-educated survivors. That's a facilitator. And that's also what they mentioned. They said in several studies that they also want early information. Quite often, survivors also stated that it's they like it like from adolescents on already, and then repeatedly the information, so that they're finally really empowered and also know how does it continue after the transition. Looking at social environmental factors, so survivors also said for sure they want to be responsible for themselves, but still quite often they said some support from their parent, they still like it, and that's kind of also a facilitator for them. For example, when the parents, they go with them to the hospital, but finally they go alone to the visit. But still just knowing that there is this also kind of practical support. From survivors' personal feelings and emotions perspective, it was also mentioned that when they kind of identified themselves as cancer survivors, that's rather a facilitator. And not surprisingly, those who are kind of concerned about their own health or also have cancer worries or maybe also suffer from late effects, for sure, they go rather more frequent to the visits, and there's less loss to follow up, and they continue also follow-up care after transition. In the adult setting, when survivors said when they kind of have a confidence in the adult physician they go to, when they think they have a physician who understands what their problems and needs are, that's a facilitator, and also kind of having an environment they know, or maybe also when they could visit the adult department before the actual transition. That's a facilitator, and also receiving kind of insurance counseling when they are then responsible themselves. And yeah, I don't have to say it again, communication is really key between all these disciplines, so survivors, but also parents, and especially also between the healthcare providers. And lastly, looking at kind of structural circumstances, what really was mentioned frequently also by the survivors themselves, that they for transition was important for them and was a facilitator, and there's kind of this gradual transfer. So when it's not saying at a certain time point, now it's time to go to the adult department, but kind of preparing them, maybe also over several visits and several discussions and meetings. And that also the transition process starts early in adolescence, that they have the possibility to meet the adult oncology team before they really have the first visit. Also having, for example, combined visits with pediatric and adult oncologists. And also, for example, kind of practical things. So when they really have their first visit in the adult department, that they already have their scheduled visit, so that they don't have to first schedule the appointment themselves, so that it's kind of an easier start there. Exactly. Yeah, and so as you can imagine, so what I've shown you with these different barriers and facilitators, it's also kind of good to understand that some of these barriers are really targetable. And I think also we as physicians can also think ourselves what could be, what we could change, what we could target. And also there are other facilitators which just can be strengthened, and then it makes the whole transition process easier. And for that purpose, there exist already few, but really not a lot of transition tools. And those transition tools that currently exist, they're rather focusing on the survivors. So really to prepare the survivors to explore their knowledge gaps, to explore fears or uncertainties that can be tackled in the next appointment. What is rather missing at the moment, these are also transition tools which looked at structural aspects, or tools where also these knowledge gaps or fears of parents could be detected. And also tools are at the moment missing, or at least I'm not aware of, that also help to educate the adult physicians and to see what's their needs and where are their knowledge gaps. There are different kind of transition tools. Now I really only like to focus on 3 scales from Klassen et al. From Canada. And the first of these scales is the Cancer Worry Scale. I will not go into detail, but as you can see, it's really kind of a short scale, just 6 questions where they can have 4 answer options to between strongly agree and strongly disagree. And it's really kind of detect their fears about different things. And then this might also really help when this scale is once completed to also see where are the fears and where are things that can be tackled, or is, for example, psychological support needed when it's not already existing. The second scale is the so-called self-management skill scale. It has the same setup, also with 4 answer options. And there it's really to see how much are the survivors kind of in charge themselves for their health, or how much do they rely still on their parents. And also here to see where are points where they can be strengthened, or it may already start when you see, for example, in this scale that a survivor really relies a lot on its parents, and he does not really answer the questions. He says that maybe he does not really know his cancer history. So that can be that in a next appointment, you then take explicitly the survivor first alone in the room, and then in a second step, the parents. So to really gradually kind of, yeah, teach them a little bit. And the third scale, and I have to say these are all really validated scales, is one which looks rather at the expectations of the survivors. So what do they expect also from the physicians, from the follow-up care visits, and from the whole setting? And these 3 scales combined, or kind of an adapted, the self-management skill scale, is the so-called transition queue. So that's also really focusing on the self-management, and the 3 scales I've shown you before, they are really for childhood cancer survivors specifically. This one here is rather general one, also for adolescents with other chronic diseases, and it can be really used already from the age of 12 onwards. And for example, what we do here in our clinic is that when they are a couple years off treatment and around the age 14, 16 years, so we really start giving them this transition queue before the visit, and we ask them to complete it. And then you see for your clinical visit, is there a point where you could tackle, where you could kind of strengthen it, or things that you can then talk about with the survivor. And it's really a tool that can be answered in a couple of minutes in the waiting room. And I personally think it's really a benefit of using it. And this leads me already to a brief summary. So I think, or what I tried to show to you, is that transition really is a process, and it needs a preparation, and it needs a preparation of all involved people, from survivor to parents, and especially also adult physicians and all the different disciplines. And it's really an interdisciplinary approach. So it's not something from oncologists only, it needs all the other disciplines too. That the transition itself is really, or should be really, individualized. And also finally, which transition model is used should also be kind of individualized based on what's available in the country and what are the needs of the survivor. Then education and communications are really, really important. And transition tools really can help to see where are knowledge gaps and how can survivors be supported. And maybe, or hopefully in the future, there will also be kind of transition tools to prepare physicians or parents. So that's really also, as for other things, also for transition, it's not one size fits all. So it really has to be adapted to each needs and personal needs. And yeah, I'm happy to take questions.